to see the webinar and listen to it again. And for those who did not have the opportunity to join us right from the beginning, you'll have the opportunity to listen in and to send it to some of your colleagues. If you are having any technical assistance and need any technical assistance during the webinar, please email Julie Parnell, J-P-A-R-N-E-L-L, Julie Parnell at oralhealthkansas.org. We have 50 people on the call now. We can hear the telephone line clicking, and so we know that there are a lot of people listening. This is just a delightful experience for us. We are so excited. I am Marcia Manter. For those of you who have not met me, I work for Oral Health Kansas. We are the state advocacy organization, and my role is especially public awareness and education. I design a lot of educational programs and do a lot of articles, particularly for early childhood. You probably have seen a number of our articles. We thank very much our partners in including them in newsletters. My work began in oral health in 1997. I was a consultant with the Head Start Technical Assistance Center, Community Development Institute, in 1993. And in 1997, all of a sudden, our Head Start programs found that they could not find dental services, particularly for pregnant women, infants, and toddlers. This was new for us because we had just had early Head Start. And so I'm quick to say I am not a dental professional, but I have learned fast. And they said to me, Marcia, you are a special projects person. You do something about it. And that has been my beginning. So I now know the difference between periodontitis and I can't even say the word then, toothlessness. And obviously I can't pronounce it, but I know what it means. I'm delighted to be working with you on this initiative. Oral health has been a career changer for me. I made a commitment to myself and even said it out loud. I want to stay and work in the field of oral health for as long as I can work. And some people are beginning to wonder just how long that might be. So it's great for you to be here with us. We are so excited to be offering this particular webinar on motivational interviewing. A number of years ago, on a listserv, I saw motivational interviewing come across, and somebody said, oh, isn't it great, Dr. Weinstein's article on motivational interviewing in young children? And I wrote to the National Oral Health Resource Center and said, what is this? So they sent me his article, and I was fascinated with the whole process. I am, by academic background and by all of the work I do, a communicator. And so when I saw motivation and interviewing, I knew I had to learn something more about it. And since then, I've read, I've listened. We even were fortunate enough through the Bureau of Oral Health to bring Dr. Weinstein to Kansas for a day-long workshop when we were working in the area of children with special health care needs. And so since then, we've been talking about how do we begin to build the expertise of motivational interviewing as another tool to support families make changes, particularly in oral health. We know we can use motivational interviewing in all kinds of aspects, whether it's stop smoking, whether it is registering regularly for Medicaid or children's health insurance programs. It can be used in a variety of ways. But because we are focused on oral health in our office, we are using it to help people understand and work with oral health. We are so pleased. This is a great audience, and we had about 85 signed up, and some of them signed up, but they're probably listening together with others. You will see on the screen to the right my panel that shows what you can see, and it says there are ways that I can reduce the panel, and I will in just a minute by clicking the red button. You can type your questions here. You will see right on the screen a section that says questions. I'm kind of looking for it right now. Here it is, questions. And you can check out, you can write your questions in there at any time, and we welcome you doing that. There'll be several times during the webinar when we can do questions. I'm sorry, I do want to acknowledge our sponsors for this, Kansas Cavity Free Kids, and you will hear more about that and meet Kathy Hunt if you've not already. We also are being funded by Head Start Dental Home Initiative, PalTech, which is a technical assistance organization in the East Coast for Head Start, and they have been working with the Dental Home Initiative for this period of time. And then also thanks very much to the Kansas Bureau of Oral Health. They are strong partners and have been providing support, energy, guidance, and resources and funds. So thank you for everyone. I'd like now to turn this over to Kathy Hunt. Kathy is my partner, my friend, my colleague who will work till midnight and 1 o'clock in the morning doing projects, and then I pick it up at 6 in the morning again. We have had a great partnership since 2004 when she called me and she said, I want you to explain some things for me. Come over to my house, which I did. Kathy, thank you for your leadership. You are the founder and the director of Kansas Cavity Free Kids. It has really made such a significant difference in our state, working very hard to keep children cavity free until kindergarten. So I'm going to turn it over to you.
Thank you, Marcia. I'm very excited to launch our first educational session on motivational interviewing. This is an important ingredient to add to the support services that Kansas Cavity Free Kids has already put in place with the goal of children reaching kindergarten cavity free. Over the past 4 years, we've been engaged in supporting and implementing outreach dental services where gaps in care have been reported. We've advocated successfully at the state level for increased funding and changes in legislation that improve oral health. And we've also identified and developed additional educational materials for early childhood, such as the 0 to 3 early childhood oral health curriculum that Marcia and I recently worked on and presented to a lot of you. And we also have the new issue-specific parent handouts called Fast Facts. As a parent of 2 grown sons, I firmly believe that parents want their children to be healthy. For them to have healthy growth and development so that they can do well in school. The challenge can be that sometimes parents don't know what actions to take, sometimes their actions are not effective, and sometimes, for whatever reason, they just do not take action. And that's where you play such an important part. Through my opportunities to help support your work, I've developed so much respect for the commitment that all of you have to families, to children, and to your respective professions. And I believe that you want the absolute best for the children that you work with. In your desire to be helpful to parents in their roles as caregivers, educators, and role models for their children, you want to know efficient and effective ways for children and parents to adopt good oral health practices, and helping you to achieve those goals is why we're here today. I hope that we've been successful in getting the message out that while tooth decay in other groups has remained steady or declining, we're actually seeing more decay in children under the age of 5. In fact, 34% of children are entering kindergarten with untreated decay. And as with many diseases, decay does not affect all children equally. 80% of decay is occurring in children who are in minorities, have special health care needs, or live in families with low income. What's sad is that tooth decay is entirely preventable. We know how to prevent decay, and we look to all of you to help deliver that message to every parent and caregiver, as well as the professionals who provide their health care. Thank you for sharing a part of your day with us.
Kathy, thanks so much. And again, I have to say publicly, you have done an amazing job of building care for very young children by recruiting dentists, hygienists, and early childhood professionals and home visitors to share in our vision of Kansas cavity-free kids. In fact, you know, this really does need to be repeated. More very young children have tooth decay than ever before. It's not just tooth decay. It's a disease. It's an infection. And if we leave it untreated, and parents really don't seem to realize that the tooth decay makes such a difference for their children's lives, if we leave it untreated, it goes from a small decay to a large decay spreading to other teeth, and we go from a crying baby to a child that you see in the left-hand corner who is dangerously ill. That leads me to one of our terrific resources in Kansas, Dr. Charles Abick. Chuck, I'll call him this morning, is a general dentist who has a personal commitment to serving children. He is a practitioner. He's the senior dentist at Salina Family Healthcare, along with another dentist and a very strong team of hygienists and dental hygienists. They are making a difference in their very large community of several counties in improving oral health. He's a graduate in general dentistry from UMKC, and he's taking time and has taken time and is taking time now today with us here in Topeka because he recognizes how motivational interviewing can support everyone's interest in having a healthy mouth and to keep children cavity-free. He's like me and Kathy. He's a learner of motivational interviewing and eager to do whatever he can to build his own expertise and that of others. So welcome, Chuck.
Thank you very much, Marcia. We've all heard that parents don't think that tooth decay is a serious problem. And we also hear parents say, I'm not going to worry about these baby teeth. It doesn't matter if they get cavities, they're just going to fall out anyway. And if the child develops pain from those cavities, it doesn't matter because I can take him to the dentist to get them taken out. Even some parents are unwilling to do that. Also, we know that access to care has been a problem. And although that problem is getting better, there are some places which still do not have good access to care. But we're finding that access to care isn't the only problem, because in some places where there is very good access to care, we find that some parents still don't take their children to the dentist. When I was a dental student, at first, in order to help my patients, all I did was educate. I told them what they needed to do to take care of their teeth, and I provided them very good rationale. As I saw them back for their checkups and their recall appointments, I found that that wasn't always effective. So what did I do? I educated them again. Maybe this time providing a bit more stronger message, providing a bit more rationale. I would attempt to persuade them why they needed to take care of their teeth. I would get frustrated because this wasn't working, and I would turn up the volume. I quickly realized that education alone is not always effective. And I was looking for a new way to influence parents to change their behaviors. My search led me to a better way to support children make the behavior change that's needed to keep their children cavity-free. And this approach is called motivational interviewing. I first heard about it in dental school, and I've read articles about how it can be implemented in a dental setting. However, I'm a learner just like you. Let's start out with what can motivational interviewing do for you, and what can it do for me? I'm convinced that once I master motivational interviewing, I can be a more effective communicator, educator, and persuader as a dentist, and do my part in keeping children cavity-free for life.
Dr. Abick, thank you so much. I'm really looking forward to an ongoing partnership with you, with Kathy, and there will be multiple ways that now in Kansas we will be demonstrating how to use motivational interviewing, particularly as we are working with young children and their families. We have with us Steve Brazil. Steve is a trainer, a leader, an educator on motivational interviewing. He really began studying this in 1998, and since then he has taken training himself. He has become certified in motivational interviewing, and what brought him into working in the dental field is that he became a consultant and a trainer for Philips Sonicare, and you'll hear more about that later. I think the good news for us is that he lives and works in Wichita, so we in Kansas have the benefit of having him close. Kansas Cavity-Free Kids and Oral Health Kansas have every intention of having him become a trainer for us and a coach for us along the way. So you'll be meeting and hearing Steve, we hope, at some point live at workshops. So Steve, welcome.
Hopefully
Thanks.
live, right. Thanks, Marcia, and good morning, everyone. I'd like to start by taking a big picture view of MI, and that's what I'll call it from here on out, the motivational interviewing, by looking at some of its components and how it seems to motivate people to make changes. And then we're going to hear how MI sounds when it's used in a consultation about oral health care, and that'll be here in a few minutes. So first, MI is a conversation between a parent and a home visitor or a dental provider, and from here on out I'll kind of refer to them as providers. And this conversation is focused on improving children's oral health care. It's not a consultation where parents are simply given information on how to provide better care. Instead, it's a way of parents and providers working together to develop a plan that works well for a particular set of parents and their child. It's really a back and forth conversation. And also, and this is very important, it's a guided conversation. The provider strategically guides the conversation in a way that keeps the focus on improving oral health care. And this guiding component is a vital part of MI. Without this, MI is not MI. And we're going to hear some examples of that very soon. And once you hear the examples, I think it will bring it to life. By having this particular style of conversation with parents, a provider can increase the chances that parents will make positive changes in how they care for their child's teeth. Of course, there's no guarantees, but MI has shown itself to be very good at engaging clients and getting them to increase their motivation to do things differently. MI appears to work through eliciting and activating a parent's already existing motivation. Now, I know sometimes that might be hard to see where the motivation is, but that's what MI focus is to bring that out. So instead of trying to install something into parents, we use MI to tap what's already there and bring it out and then use it in the service of improving oral health care for children. MI really views motivation as an interpersonal phenomenon. In other words, that we view it as motivation as something that can be increased or decreased simply by how we talk with parents. So we have an impact simply by using conversation to greatly increase the chances that parents will change the way they deal with their children's teeth and make improvements in that. So to have this guided conversation, we have to employ some really essential communication skills. We have to ask questions. We have to provide good information. We have to actively listen. And we need to be genuinely curious about our parents and kids. And I know that you already do these things. But with MI, these communication skills are used in a very particular way, and they're based on a very particular foundation. So we're going to take a look at that foundation now, and you should see a card or an ACE card on the screen, and this is the foundations of MI. And it's often referred to as the spirit. And it's really important because everything else that we do in terms of the skills of MI sit on top of this foundation. So let's take a look at ACE. A is for autonomy, and that means that parents are always the one who decide what to do or what not to do. We don't give people autonomy. They already have it. We just have to remember that, and we have to honor it. There's a bit of a paradox in human behavior change. When people feel pressured to do something, they tend to resist doing it. But when they feel free to choose, they're more apt to change, and oftentimes in a positive way. The second, or the C, is for collaboration. And that basically means that providers and parents are actively working together to make positive changes. So you can think of it as experts working side by side. The provider has expertise on good oral health care, And the parents have expertise on themselves, their child, and their family. And this collaboration can lead to better solutions. And it also encourages parents to be active participants rather than passive ones. And in other words, you don't have to do all the work. And the last, the E, stands for evocation. And that means we want to elicit parents' ideas, wants, needs, knowledge, and motivation. And again, we're trying to elicit rather than install. So people tend to be more motivated by what they hear themselves say as opposed to what they're told. So we want to try to guide this conversation with parents in a way that we have them talk themselves into changing rather than us try to persuade or convince them to change. And it can be helpful to keep in mind that parents are more apt to change the ways when they deal with their child's teeth when they see the importance of changing, they feel capable of changing, and they feel ready to make a change. MI can help parents become ready, willing, and able to change and improve the way they deal with their children's teeth. So, with these things in mind, the spirit, willing, ready, able, we're going to take a look at how communication skills are strategically used in a special way in MI. So first, open questions are used to elicit from parents the reasons to improve oral health care, as well as the ways they think they might be able to do that, along with our help. So open questions, very important. We also want to affirm parents' attempts at change and be supportive of them as they make positive changes. I think all of us who've tried to change know that change can be difficult, okay? And particularly when it involves a child who probably has a mind and ideas of her own. So affirmation and support, very important. And next, listen and learn. We want to listen and learn from parents so that we can help them develop a realistic solution to their child's oral health care needs. A good plan is one that will work and that parents will do. Okay? A plan that a parent will not do is not a good plan, no matter how good it may seem to us and how good it is based in science. A good plan is one that they have to follow through on and have to be, or have to see the need and their ability to do it. Sharing information. You have a lot of good and valuable information, and it needs to be practical, relevant, and offered when a parent is receptive to hearing it. That's what makes for good information exchange between parents and providers. Practical, relevant, and offered when a parent is receptive to hearing it. And as professionals who are trying to help others, we often give out more information than we need to at any one time. Asking parents open questions and listening more is really key to our success, which also means the key to parents and children's success as well. One way that I like to think about it is that patients or parents are more than just information receptacles. There's only so much they can take in at any given time. Now, I know that as helping professionals, all of us are taught to solve problems for patients. But just remember that you don't have to have all the answers. In fact, you don't have all the answers. However, you and the parents together do have them and can figure them out together in a collaborative sense.
Steve, thank you so much. And by the way, we are getting some questions, but this is a question to all of us. Someone wants to know when or how they can get this PowerPoint, and it will be archived on Oral Health Kansas website. So you will be able to see the PowerPoint. I've learned a lot from you, Steve. I knew basically about motivational interviewing, but you've given me some words to think about, like the word spirit of it. You've given me over and over again the answer, I don't have to have all the answers. Now that's a tough one because I've studied a lot and I think I know all the answers. And I think the whole point is looking at it as a conversation. I tried this out yesterday because I worked with a group of 12 teenage moms for about an hour, and I've used some of these skills, and you know it turned out to be a much better conversation than me lecturing for an hour. So thank you. You see that there are some questions here, some opportunities. Someone has said, thank you so much. I think it might have been because we said the PowerPoint would be available. I do have a question. You said that what we do in motivational interviewing either can elicit the motivation from the parent, can help the parent identify and realize what's motivating them in terms of taking care of their children's oral health, but you said we can also, by what we do and say, decrease the parent's motivation?
Right, right. In having conversations with patients, whether they're dental patients or medical patients or substance abuse clients, the way that you interact with somebody can increase or decrease their motivation to change. And it's very, very interpersonal. And so the way that we talk to people, the way that we elicit from them or persuade them or force them, if we're too confrontive, can, in a matter of moments, increase or decrease their motivation. And so motivation isn't a character trait that somebody has. Motivation is an interpersonal phenomenon that can be altered by the way people are interacted with. So if I wanted to have a conversation with Dr. Epic, I could, in a matter of moments, engage him and increase the likelihood of him at least having a discussion about a potential change, or I could pressure him and confront him even subtly and get him to turn off the potential change. In fact, by the way I talk to somebody, I can take somebody who is thinking about change and in a not good conversation have them move backwards to then thinking it's not about changing in a matter of moments. So I can do damage by how I talk to somebody. I can take them backwards in the process of change. So it's very powerful how we say things, what we have.
Now I realize why my husband always says, I'll decide if I'm going to do something. That was his favorite expression to me. I'll decide if I'm going to do something. Okay, now I know. Okay, I'm hearing you all say, I think I understand, but I can't really picture this about exactly how it's going to work. Can you give me an example?
Sure.
Sure.
We'll do a little kind of vignette of what it might sound like.
So we've recruited Jeanette Dellinger. Jeanette, in fact, is the person who learned about motivational interviewing and at some point from Steve. She introduced us to Steve, so we owe her a big favor, and now we owe her a second favor because she is going to role play with Steve how it might sound with a home visitor. So Jeanette, welcome.
Thank you, Marcia. Can you hear me okay?
We can hear you. Yeah, thank you.
Okay, good. I just wanted to check since I'm in my home office. I want to say that Steve was magnificent, really. He's a wonderful educator, and our full Sonicare professional education team took an advanced and a basic and advanced course of motivational interviewing with Steve as our instructor. And I know our whole team were very, very thrilled to have his assistance. We found that through reading that motivational interviewing was starting to really get into healthcare. It originated back with substance abuse and drug abuse counseling and has therefore moved into healthcare and now dentistry. And so there are definitely some clinical studies that showing that it is relevant and it is working. And I will tell you that as a professional educator with Phillips, I still do some temping, and I'm able to actually put my motivational interviewing into practice. And I'll tell you what, it really does work. It's very simple, easy to use, but part of helping our patients change behavior is the fact that as clinicians, we have to change our behavior because it's a whole different way of speaking to our patients. So we have to change in order to help our patients.
Let's start with an example then. Thanks, Jeanette, for being part of it. Jeanette is going to be Karen, the mother, and you see her little girl, Sarah. On the left-hand side, you meet an actual home visitor, Myrna, right-hand side, Myrna.
That's me. I'm Myrna.
Yes, Myrna's voice has changed this morning. So Steve is going to be Myrna. Myrna has been a home visitor in Early Head Start, and parents as teachers and is now a home visitor in the Manhattan-Wamego area. So she and Karen and Sarah agreed to demonstrate by their facial expressions and their gestures and how they're sitting. So Myrna has been a home visitor with Karen for several months, and they've covered a number of things like the child development, and is Sarah at just the right stage of child development, any particular services that Karen and her family are needing, how they deal a little bit with sibling rivalry, what are the kinds of dental service, not dental, but healthcare services that are appropriate for Sarah at her age. And so Myrna knows now at the next few home visits, she is going to raise the question of oral health. And so we'll start the scenario.
Karen, one of the topics we haven't talked about is oral health. So what questions or concerns do you have about Sarah's teeth that I can think about before next week?
Well, I read someplace recently that I need to be helping Sarah brush until she's older, like 7. But I don't know how parents are supposed to do all that with our kids to get ready for school every morning and then put them to bed at night.
Yeah, I can imagine. Those times of day can be busy for everyone. In fact, it can get really stressful as well. And you're very right about how helping Sarah when she's young can be really, really important.
Well, it'd be helpful if there were more than 48 hours in a day, or 2 sets of parents, or both.
I understand. Well, what if we were to put our heads together next week and see if we can figure this out together?
Ooh, sure. I think I'd like some help.
Great. We got a plan, so I'll see you next week.
Steve, you want to just do a quick review of the different points you were making in this first part of the scenario?
Sure. Well, we talked about guiding earlier. And the first part is that I'm the one who kind of brings up oral health care. Right? So I'm kind of guiding because I want to get to that. But I also ask her and elicit what are her concerns about it. So it's guiding, but it's also then pulling for her, what is it you'd like to talk about, even though I've kind of selected the area. And then her issue is of being very busy and having time to fit it in. And I want to make sure that she knows that I hear that, I understand that, so I reflect it back. But I want to, again, guide the conversation back, pointing to how important it is. And so I affirm her for what she's read and bring the conversation back to, again, the importance of the oral health care. She then, again, kind of jokes about it being very busy. And then I move towards, oh, let's work on it together in a collaborative sense. And so I've heard her struggles, but I'm just not going to let it be that. But I'm also not going to say something like, well, but you know it's important, so you're just going to have to find the time. Or if it weren't that important, so on and so forth. I avoid all those sort of persuasive arguments, and again, trying to draw out of her what's important and what she's willing to do.
I can hear a lot of the home visitors and dental hygienists who are part of our participants today saying, you know, I'm glad to have had this first part of the scenario because I can hear myself doing some of that. So I'm patting myself on the back saying, okay, I get it. I can now maybe have a different name for it. So let's go on to the next week.
Okay. Karen, the last time we met, we made a plan to talk about finding time to help Sarah brush. Is that still a good topic for today?
Yeah, I think so, because we aren't doing any better, that's for sure.
Okay. Okay. Well, one thing that research tells us is that nighttime brushing is probably the most important time to brush. So what if we start with that?
Well, that's great, but really that's the hardest time.
Okay. Well, tell me a little bit about the bedtime routine here at your house.
Well, the 2 older boys, the older kids, they should be in bed between 9:30 and 10, and at least they're in their rooms by then.
And Sarah, what about your bedtime activities with her?
Well, my goal is to have her in bed by 8, so we begin about 7:30 after some playtime after dinner, which we finish about 6:30. Then that's the time my husband plays with the kids. They take a quick bath, get her in the pajamas, and read a book. So it's usually about 8:15, 8:30 by the time she's asleep. So like I said, it's busy, and I'm not sure we're going to know how to really make that brushing work. Do you?
Well, I can tell you about some of the creative things that a few parents have done to fit brushing into a busy life of kids, and you can see if any of them sound good to you.
Ooh, I like the sound of that, so go ahead.
Okay. Well, One set of parents helped their daughter brush while she was taking a bath. So that saved them a little bit of time, doing two things at once. Another one that I've heard is a dad took his toothbrush into his son's bathroom and began brushing each night right along with him. And that one worked well for them. And a third idea I've heard is that some parents read a book to their daughter, one set of parents read a book to their daughter as she brushed her teeth. And then they checked her teeth when she was in bed and even made a game out of it by using a little flashlight to try to catch any food that was left in her mouth. So what do you think of those sort of ideas?
Wow, those are pretty creative. I think I'll try the one where I brush right along with her. And in fact, I can get my husband to brush with the two boys.
Well, sounds like you got a good plan there, and I'd be really interested to see how it goes when we meet again next week. See you then.
So, thank you, Jeanette. You're an excellent parent. Steve, thank you for this. So how realistic this was? That is, in fact, a question. Is this realistic?
Yes, it's realistic to how it can sound. Now, what you're going to run into, which is too much to get into in a 1-hour seminar, is when the parent is less receptive or is more resistant, which MI can also handle as well. This is a parent who's more, I'd say the issue is she sees some of the importance but is more held down by knowledge about how to go about doing it, capability, so to speak, or competence to bring it off. Some parents are going to be much more resistant and not open to hearing things. And there are ways to deal with that too. They're a little bit more complicated. So.
And those are the types of things that you might cover in a longer format.
Right. When you have a day to do something, you can talk about the more resistant customers, the more tougher consultations, where you may be having to say some things that they may not want to hear, but out of need or safety that you may have to. So, sure, that can be part of it as well. Right. MI tends to be very, very subtle. You can sound very nice about the way you do things and be confrontive. And so with MI, it's very, very subtle language in how you use it to guide. So if you hear it, you may think, well, that's what I already do. In some cases, that's true. In other cases, there are very subtle uses of questions or guiding that are hard to hear unless you kind of know what it is that MI is and kind of guide the conversation that way.
So let's review a little bit. I put up again this Foundations of Motivational Interviewing, and by what you were talking about, the subtlety, it begins to give me another word for the spirit of it.
Mm-hmm. Right. In the second piece of the scenario, you're going to always notice that I ask permission. Is it still okay that we talk about this? I can give you some ideas, and then you can decide what to do with them. It's collaborative in terms of I give ideas and say, basically give them permission to either say, none of them sound good to me, or this one sounds good to me. I spend time with open questions to elicit what the scenario is around the house so that I can get a sense of what suggestions I might make. But again, it's always up to the parent as to what they choose to do. It's very important for me to know what things are like and what they, in this case, the scenario is at their home at night, so I can get a sense from them of what it looks like so I can be more helpful. So a lot of autonomy, they decide. It's me, and in this case, Karen, working together to try to figure out a potential solution. And then really listening from her, what do you want to learn about? What are your issues? What are the problems you're struggling with? What is it like around your house, and how can we solve this together? It's a really good example of what ACE would sound like.
So here's the question. This comes from another one of our listeners, and she's obviously an experienced home visitor. So what about those parents that claim, we're good at brushing here, we don't need any help, thanks very much, but you can obviously see that either they're not brushing or they do it very rarely.
Right. And
this is a home visitor who is being very observant.
Okay. One thing that you can do when you're noticing things where the data doesn't seem to meet up with what you're seeing is to do something that we'll talk about in training called bringing up concerns, so that it's not them that's bringing up the concern, as in this case, but you're bringing up the concern because they don't have it and you do, and so there are ways to do that also that have an MI style to that. And there are ways to talk about, this is a question I think Kathy had asked me about before. MI was invented back in the 80s to have conversations with people who didn't necessarily, who weren't interested in the change that you were wanting to talk to them about. That's its history, was how to help people change who are reticent about making changes. And if at that time was with substituting clients who are kind of notorious for not wanting to change or not seeing a need to change, and how you have conversations that motivate them to do something differently. And sometimes you have to bring up with folks concerns you have that they don't see or don't want to discuss. And there are ways to do that that keep it from being just a confrontational battle and increase the likelihood that you might bring them along. But there are never guarantees. There's just an increased likelihood that you'll get further with this and have better outcomes or results if you can do it in this way.
So the idea then, in this particular case, is the home visitor is observing that the child's teeth clearly aren't brushed, maybe time after time seeing some food debris, and knows that she's brought this up, and then will be able to think through the parent's personality and her relationship with that parent and how to, I'll say it, put the issue on the table.
Right, exactly. And the better relationship you have with somebody, sometimes the more directive or for lack of a better word, pushy you can be. If I have a good relationship with you, Marcia, I can sometimes be a little bit more directive because we have a bond between us and we want to take it. If the bond isn't there, it needs to be confrontive and the person backs away.
Something I learned a long time ago as I was a consultant in organizations and in business management is what they talk about, the 20-60-20 rule. I think my math is about right there. 20% of the parents are going to be extremely receptive and take in, most people say to me, I never knew about this in terms of oral health. So they're taking it all in and they're changing behaviors. Karen's an example. 20% do not care and have a defensive stand right from the beginning, perhaps with a number of things that are part of home visiting.
Right.
And then there's 60% on this continuum. And the higher continuum of the 60% can be moved fairly readily into, so it becomes 40% who are interested in doing things.
Right.
And then the longer we have to work, or the more the parents hear information in a different way, we begin to bring people closer. I keep coming back to the incredible changes that have come about in terms of smoking. I am of an age when almost everybody smoked. The earlier we could start, the better. And then gradually, people began giving up smoking because they were hearing the messages from so many different directions. Okay, so let's kind of move on and see. I don't have any other questions, and I'm looking at time here. So here's a chance for someone to ask a question. Or Jeanette, please feel free to jump in because you've been practicing this too. Have you met a resistant patient or a resistant professional who says, ah, well?
Well, you know, in our business, when we're speaking with patients, it's so brief. And I try to really focus on just one element at a time, whether it's better brushing habits, whether it's interproximal cleaning, you know, whatever the case may be. Maybe it's talking about diet or nutrition. I just try to kind of focus on one thing at a time because I don't know if it's like many of you, but for me, if you give me a whole bunch of stuff to do, I'm going to walk out and probably not do any of it. So really focusing on kind of one thing for a patient to take and change at a time, knowing that I'm going to see them again and we can work on the next issue. So I just target one thing, and that maybe I have 3 to 5 minutes to really work with them and find out what they can do in their oral hygiene routine that will allow them the opportunity to work on something, one item, until I see them at the next visit.
Thanks so much. Now, I don't know about you. Oh, yes, Kathy?
I just wanted to jump in real quick, going back to Marcia's comment about smoking and the changes that we've had, and then Steve talking about the history of motivational interviewing and the impact it's had, I wanted to pose this question to Dr. Abbott because he was sharing a little bit of this information with me a few days ago about some actual research proving that once you feel comfortable and competent at using this strategy of motivational interviewing, how much of an impact it really can have. Dr. Abbott, can you kind of share in the field of dentistry anyway when they've used motivational interviewing?
I sure can. There was a dental researcher who really wanted to study the effects of motivational interviewing in a dental setting, and the question they wanted to investigate was this. If you use motivational interviewing in addition to patient education versus patient education only, will it make a difference? And they studied this in a dental scenario where they were educating mothers of young children on how to take care of their teeth. And they used the motivational interviewing techniques, and then they did 1- and 2-year follow-ups of the children's teeth. And what they found was motivational interviewing was quite effective. In fact, the children who were in the motivational interviewing groups, on the average, had about 50% less cavities. So this was demonstrated in a dental setting, very similar to our example, that it was indeed effective.
Great, thank you. I think that really helps us to know, that this is a tool that if we take the time to really engage in the learning and to feel confident and confident in it, that it can have an impact in the work that we do every day.
Yeah, I think we all look for examples, and when we have the example on our own of seeing it work, as Jeanette has had and as Steve and Dr. Abbott have had, it clicks that I keep trying it. I think we need that. It's like losing weight, 1 pound down, then the next pound goes down, or whether it's running, you do a mile, you do a mile and a half, none of which I do. Okay, so you've heard a little bit. This was intended to be just an introduction to give you an opportunity of, I do some of this very well, and I'm glad there's a label for it, and I have seen it work, and it is part of my style. And then also, I'm very committed to the work that I do as a home visitor and a dental hygienist and a dentist. I think I'd like to learn doing more of this. There are several ways, and so I can offer some, and let's see if any fit for your style. There certainly are books. Before the webinar, I went on Amazon and I found one page of multiple pages. There were 12 books on motivational interviewing, and they had all kinds of different information and pieces of information. And probably, if you go to the library, you'll also see motivational interviewing books. And if you're on Nook or what's the other one, you can probably download these and read about it. So if you're a reader, that's really one way to go, and you'll get more reinforcement, more of the language, more demonstrations. Also, you can learn by listening. There are motivational tools that motivational what do I want to say? On books on tape, CD, and you can hear scenarios and you can listen. So if you're a learner, the way I am as a listener, that works very well. By the way, I did check up on Amazon for a CD on motivational interviewing, and it suggested that I listen to the Horse Whisperer. There's some relationship there to motivational interviewing and the Horse Whisperer.
I actually use horse training videos in my training.
All right, so horse training videos. The other is YouTube. There's everything on YouTube. There's a lot of motivational interviewing, so you can just go into the search bar, say motivational interviewing YouTube, and you get all kinds of examples. A lot of are homemade, a lot are very good, and so if you like to see it that way, you can go in more depth. The other is actually practicing, being able to ask questions, watch somebody else do it, play with it a little bit, and so we can give you a list of books. We can also pull out some YouTube videos that we think are pretty good. And then we have a commitment, and that's part of our Caltech Children's Dental Home Initiative, Head Start's Children's Dental Home Initiative with Kansas Cavity Free Kids, is that we have funds to do one-day workshops on motivational interviewing. Steve, and if Jeanette has time, she will join him as a trainer, and we'll have the opportunity to take your own scenarios and begin to do some training. So this is Steve's suggestion, that it'll be a really thorough review of the components of MI and scenarios that are relevant to home visiting, just like we did today. And then we have a chance to practice. I'm sure that each of the steps you gave us and each of the spirits you gave us of autonomy and doing it collaboratively and affirming are all that we'd be able to practice. And also some tougher situations. Somebody said, what if the person says, well, what if the parent is consistently defiant? This is one of the questions. What if they're consistently defiant? And you see that the decay is growing. It becomes pretty obvious. And at what point do you begin to report neglect to SRS? That leads us into a whole nother workshop and a scenario. And I'm really glad that someone asked that, because we have an early childhood oral health advisory council that has been addressing neglect, oral health as neglect, and beginning to do workshops and advice for people. Kathy, do you have, go ahead.
Yeah, and for those of you who are with the Head Start, there is an APM meeting coming up in Salina in
the 11th of April.
The 11th of April. And we will have, I think the health specialists will be there and the program directors, and we will have actually Marcia and Sarah Pritchard from the Panda organization will be speaking on that very topic. So that's just an initial talk, but as she said, EchoHack is really looking into that, and we do want to be able to clarify that a little bit more and help you all understand. That is a really tough topic, and it is for us as in the dental profession as well. When do you take that next step, and how do you go about it? So I'm glad you asked the question, and we're asking that question as well, and we hope that we can really bring you some more definitive answers in the near future.
And also for the Panda program, for Sarah and Delta Dental, we really are eager to do these presentations to Tiny K, parents as teachers, healthy families, healthy starts. We are reaching out beyond the dental community to everyone who supports and surrounds the parents and the child. Kathy and I will do a follow-up survey of everyone who signed up for the workshop and everyone who participated to find out more about what your questions are, what you would like to learn to do differently, we'll give you some classic books to read and some articles to read and some YouTube, and we'll like to learn what you would like to do for first yourself and then for your team. And then what kind of support do you need from Oral Health Kansas, Kansas Cavity Free Kids, and this is very exciting for us. So this is our way of continuing. So this was just an introduction, just a beginning, and we will be moving forward. This is really where it is, isn't it? This is what we are all getting up early for, staying late for, bringing our hands, asking people ideas for new ways we can work in this field. Too many children, very young children, are at this very time miserable from rampant tooth decay. So many children probably right at this time all across the country, right here in Kansas, right at Children's Mercy or Grace Med or some of the other dental clinics around the state are in surgery right now at the age of 2 and 3 because of rampant dental decay. We have a chance to change this, to take positive steps with motivational interviewing, and also our responsibility as reporters to also identify and talk about neglect and abuse. So thank you for all you do. I think that home visiting, educating parents is one of the most difficult things that you can do. This is the list of participants and our websites, email addresses. Please feel free to contact us, and we will be developing this. And the last person to make a comment, thank you very much for 2 people. Thank you so much for the great information, someone said, and we appreciate you doing this. Thank you for all you do. And the same is back to you, to Dr. Abick, to Chuck, to Kathy, and to me, and Julie Parnell, who has been standing by helping us. Thank you so much.
And thank you, Marcia, very much for your excellent job of moderating and bringing all these comments together. So we look forward to working with you all in the future, and enjoy your weekend.